Well, thank you so much, JP. It's such an honor to speak with you guys today. I remember some of those research meetings that we had and talking about some of the outcomes of it and just the wide eyes across the room. But really exciting time, and the research continues to be exciting. But I'm going to jump into Microtia Reconstruction as a way of disclosures. We've got a number of grant supports, and work has generated intellectual property. I'm a co-founder of a company called Make Medical, which licenses some of the educational tools that we've developed. So today we're going to talk about the workup of microtia atresia, talk about some treatment options, highlight some of our team's initiatives to date, and then briefly touch on some of the work in 3D printing and tissue engineering that we've done. A lot of the figures that we're going to talk about and a lot of the subjects that we're going to talk about, we go into more detail in a couple book chapters. Microtia is such a unique area to work in, and like a number of complex areas that we all work in otolaryngology, it's one where we're continuing to learn, we're continuing to develop techniques. And I just had the great fortune to work with some fabulous colleagues and collaborate with a number of fabulous colleagues, my T and Kay here, and Siva and Carol. This was from a panel at ASPO. It was the first kind of complex peds oto ASPO discussion. So I'll jump in, to talk about microtia. I think it's good to review the normal ear anatomy and just to hit some pearls that are sometimes tested upon. Embryologically, the ear develops from the hillocks of His. And so the first three are coming from the first branchial arch. The second three are coming from the second branchial arch. And those contribute to the development of the auricle, the first hillock contributing to the tragus, and then kind of like a clockwise pattern contributing to the other aspects of the helix and rest of the framework. This is a really nice depiction of all of the features of normal anatomy from a review by Craig Murakami. I was fortunate to work quite a bit with Dr. Murakami when I was out in Seattle Children's doing fellowship, and also fortunate to work with Kathy C., where we did quite a bit of microtia reconstruction. In this review, what I love about it is the amount of detail that it goes into. In the reviews on otoplasty, but just as a way of kind of having all of the normal measurements, and I just want to kind of have that for reference for the group. From a innervation standpoint, we know this is kind of a watershed area where there's multiple sensory branches contributing to ear. From a vascular standpoint, predominantly the superficial temporal artery and posterior auricular artery are contributing to the vascularity. When we look at this picture in particular, that superficial temporal artery will go up and feed that temporoparietal fascia. And we'll go into more detail about some areas where that's of importance. And so, it's amazing that such a complex, beautiful shape is consistently developed time after time. And it's also no surprise that sometimes that shape doesn't develop in that fashion. And so we see microtia and a spectrum of atypical ear development, from very slight malformation of the auricle to complete absence of the auricle. And as we do in a lot of things, we try to group this atypical development, grade 1 being where most of the subunits are present, but there are aspects where the microtic ear is slightly smaller, there's slight atypia. Grade 2, or what Nagata will refer to as a conchal type microtia, has underdevelopment of the superior aspect of the ear, but the tragal, intertragal, antitragal complex is somewhat preserved, and there's somewhat of a conchal bowl. Grade 3, what we're seeing most commonly in our multidisciplinary clinic, is a lobular, Nagata would refer to a lobular type microtia, where a majority of the framework has significantly been underdeveloped, but there is a lobular remnant. And then grade 4 being anotia. Incidence-wise, varies from 1 to 10 per 10,000. And across the globe, this can vary to some regions where it can be approximating the incidence of cleft lip or palate. So fairly frequent. Males more common than females. The right ear is typically more impacted than the left ear. Bilateral microtia we're seeing in, I'd say, just under 10% cases. And in most of these cases, there's an accompanying oral atresia, so a significant conductive hearing loss. And when we think about how the development of the branchial arches contribute to microtia, it's not surprising that there are associated syndromes and other kind of connected impacts. So craniofacial microsomia, hemifacial microsomia, Goldenhar's is one of the more common syndromes where we'll see microtia, ocular auricular vertebral syndrome spectrum disorders. And again, it simplifies things to think about the branchial arches and what other structures are a part of the branchial arch development. So the mandible, the middle ear, and so frequently these patients will have underdevelopment of their mandible and their hemiface, also cardiac and renal systems. And so those are the most common syndromes that we see, but there's a really long list of other syndromes where microtia is a component of that. And so I'll talk just a little bit about our multidisciplinary clinic. So in 2015, I started at University of Michigan and was extremely fortunate to begin to work with Dr. Jennifer Kim. And we've really grown a really wonderful multidisciplinary clinic where we have a dedicated audiologist who has expertise kind of focused on patients with microtia and atresia, speech and language development, genetics. And we've seen a large number of patients, and we're doing a fairly routine number of reconstructions. And our mission is really to be able to provide all reconstructive options and allow the patient and the family to really drive the shared decision-making and with whatever decision they choose to optimize the outcome for them. We also participate quite a bit in global outreach for microtia. And so I participate in an annual mission to Cusco, Peru. Dr. Kim is very active in global outreach, and she does missions to Peru, Guatemala, Vietnam. And these are typically very high volume, very busy trips. Education is a component of that. Very rewarding. This is just my homage to Dr. Jennifer Kim. She's just an amazing colleague. I don't know many people who are as upbeat, as positive, and as brilliant as she is. And I'm just tremendously fortunate to have her as a colleague. And then this is one of my favorite photos of Jen, where she's kind of laughing so hard. She's got the rib harvest laughter going on, kind of the side splitting laughter. But when we think about, what goes into the care of these patients with microtia, it's involved. And I've seen a lot of reconstructive surgeons who will say, we're not going to do reconstruction until the age of 8, 9, 10, come back and see us then. And I think it's really a missed opportunity. There's a number of steps that are really key in ensuring that the patient has access to, has understanding. And so when we think about kind of the diagnostic components, audiologic assessments, newborn hearing screening, speech and language monitoring. Around the age of 4, we'll recommend a temporal bone CAT scan, both to survey for congenital cholesteatoma, but also to assess candidacy for atresioplasty. And then we'll follow with audiograms following. From an intervention standpoint, really ensuring if there's a hearing loss, introduction of soft band bone conduction early on, around the age of 9 months. The earliest reconstructive option ends up being an alloplastic option because you're not reliant on the rib cartilage. Percutaneous osseo-integrated bone conduction is initially FDA approved. The earliest age would be 5. the newest option, the ASIA, the earliest age is 12. Rib cartilage reconstruction, the earliest, it's very technique dependent. So if you're doing a Brent technique, which we'll talk about, which requires less cartilage, there's typically less definition to those frameworks. That can begin around the age 6, 7, 8. For Nagata Fermin, where there's more definition, more rib cartilage involved, that reconstruction is typically starting a little bit later, around 9 or 10. And so, in thinking about that complex, involved roadmap, it's helpful for the family to see that. And it's also important to, have that experience that we kind of talked about and have that game plan in mind, because microtia is something where it's not difficult to have missteps or poor outcomes. So these are patients that have been referred to us after undergoing reconstruction at outside institutions, and the outcomes are not ideal. And it's challenging enough to do microtia the first time around, but doing revision is exceedingly more challenging. When I counsel families, it's really critical, I think, to separate the interventions that are going to occur for hearing and the interventions that are going to occur for reconstruction of the auricle. Because it's interestingly common that families will come in and have the conception that if you reconstruct the ear with the rib, they'll be able to hear out of the ear. And so it's just important, I think, to really kind of group the interventions that you're doing for the hearing and grouping the interventions you're going to do for restoration of the auricle. This is a common audiogram that you'll see in a patient with microtia atresia with that maximal conductive hearing loss. Just briefly, osseointegration, the technology has gotten quite good, and we're pretty consistently getting hearing, within normal SRTs. And it's a very straightforward, low complication procedure, easily combined with microtia surgery. So this is kind of demonstrating the percutaneous osseo-integrated option, as well as the newer transcutaneous ASIA option. And then atresioplasty is reconstruction of the ear canal. And we're all familiar with the Yarsdorfer scale. I'm not going to go into detail, but to have this as a reference, I think the outcomes are not as consistent. The risks are higher. The predictability is higher. The complexity is higher, and it's more difficult to combine that procedure with microtia reconstruction. So now on to kind of diving into options for the auricle. And when I counsel families, the first option is observation. And there are some patients that are comfortable with their little ear, and I think that's fantastic. The kind of thinking about escalated intervention, the next kind of most involved option is a prosthesis. And so working with an anaplastologist, these prostheses can look extremely good, but they have downsides in that they show wear. They can fall off if there is adhesive retention. Sometimes you need multiple prosthetics to wear kind of throughout the year, and they can be costly. So this group of patients, the gentleman on the top has a prosthetic, the young woman in the middle has a right rib reconstruction, and the girl on the bottom has a right alloplastic reconstruction. And this figure is great. This is from Dr. Lewin. I think this just shows that if you have comfort in your technique, you can get really good outcomes. Diving deeper into the alloplastic options, so MedPore, Supor, all of these options are high-density porous polyethylene. The general procedure is a peri-auricular incision. Here there's marked out the superficial temporal artery. The porous polyethylene, it can be customized. It can be kind of solderized. And nowadays you can actually get 3D printed kind of patient specific MedPore, but that's relatively recent. So previously you could kind of solder the MedPore and get a little bit more of a custom framework, because otherwise it's a bit of a one size fits all. This is from John Reinisch, and so he would harvest his superficial temporoparietal fascial flap and essentially endoscopically. He uses a lit retractor, and it's a bit of a labor intensive portion of the procedure, kind of harvesting that broad temporoparietal fascial flap through that relatively small incision, and it's impressive to see. And soft tissue coverage, the skin is covered with split thickness skin grafts and remnant skin. Looking and comparing that to autologous reconstruction or rib reconstruction, which we, I think, consider the gold standard. This is kind of the rib marked out for the amount of rib that we typically harvest. So we're typically harvesting ribs 6, 7, 8, and 9. So when is the patient ready for rib reconstruction, if that's the procedure they desire to pursue? Well, first and foremost, the patient should be fully informed and fully on board with this procedure, because it's a process, and it really requires the patient and family to be a contributing part of the healing process. Classically, 60 centimeters chest circumference at the xiphoid is what's referenced. Ideally, having 9 centimeters of the 8th rib length to serve for that helix is ideal. But as we know, I mean, there's a variety of pediatric habitus, and so chest circumference may or may not be the most useful. And so we've described a technique. We've collaborated with our radiologists, who were critically helpful in developing kind of a panoramic ultrasound for us that has been helpful and can give us detailed measurements of the rib. This is kind of a typical rib harvest site, so typically just 2 to 3 centimeters, and this is shortly after the first stage procedure. Planning for the soft tissue, if you look at kind of the axis of the ear, we're typically going parallel to the nasal dorsum, maybe slightly vertical to that. And planning, Nagata classically talks about modified W-plasty with preservation of a subcutaneous pedicle. The distinction between Fermin and Nagata is Fermin will perform a transfixion incision, a hemitransfixion incision, and transpose the lobule posteriorly, and not worry about that subcutaneous pedicle. We've evolved from more of kind of the classic Nagata soft tissue skin planning to Fermin, and have not seen issues with significant skin necrosis or issues with skin vascularization. So this is looking at a template that's obtained from the contralateral normal ear, the harvested rib, the carved framework, and after the first stage implant, after elevation. This is looking at a rib model, and the material is a silicone starch composite. It's impressively close to carving actual rib, and there are other rib simulators out there and available. But this is extremely helpful in working with residents, fellows, and global outreach. But this just shows kind of the typical amount of rib that's harvested. Again, the helix is coming from that long, nice stretch of 8th rib, and we'll thin that to begin to get pliability and get that nice contour and curvature of the helix. The base plate, the foundation for your framework, is coming from that synchondrosis 6 and 7. And that nice curvature that you see between 6 and 7 serves as a great concho bowl. And so that's kind of where we're starting from, placing our base plate. And within that base plate, we can carve our scaphoid fossa and triangular fossa deep in the concho bowl. The antihelix is coming many times from the 9th rib, or if we're splitting the 8th rib. And then the intertracheal incisor is oftentimes coming from another portion of the synchondrosis. And I'm going to talk in just a minute about where we've been getting that intertracheal complex more recently.
We lost your audio, Dave. About 30 seconds ago, your audio cut out.
You hear me okay?
Yeah.
I can hear okay.
I'm hearing him fine.
You still see the screen. Still recording. Yeah, it just abruptly stopped mid-sentence for you. I'm sorry.
It's okay. My TK, you said you're able to hear okay?
Yeah.
Okay.
It was from my it was good.
I'll keep rolling then. But if other folks are having a hard time hearing, just let me know, okay?
Yeah.
Sounds good.
So that's the first stage. We'll wait 6 months typically. And the second stage is elevation of the framework. And so we're making a periauricular incision, elevating that neo framework, harvesting some banked cartilage, which is going to allow for increased projection. We're covering that cartilage with a posterior fascial flap, which can be anteriorly based or posteriorly based. We're advancing the scalp forward. And then what we've been doing most frequently is harvesting a split thickness skin graft from the scalp, which works really nicely. You have a nice skin match. The site quickly reepithelializes and hair grows through because the follicle stays down. And then there's really minimal evidence that that you've harvested that skin graft. So what we've been doing more recently, about the past 10 or so cases, is looking at the remnant for our tracheal, intertracheal complex. And what we noticed when we excised this, we started to see within that kind of amorphous lobule of very kind of thin, nice cartilage, a shape that really worked well for the tracheal, intertracheal complex. And so it's kind of a fun process. Every time we excise this, we'll look at it. It's almost like a puzzle, find the tracheal and intertracheal complex. This is how it's integrating into the framework. And this is after implantation. Another example of that kind of amorphous remnant. But when we kind of look at it, we're able to really make out a nice intertracheal complex. That's how it's looking integrated into the framework and implanted. Not all microtia requires rib cartilage. So this is just an example of an atypical grade 1 microtia, which we use Moutarde technique and got a nice outcome. This is a young man with a left lobular type grade 3 microtia. And I think his case is so interesting. When we first met him, he came into the office, he was very kind of quiet, introverted, just a bit down, was very excited to proceed with ear reconstruction. And what I'll highlight with his reconstruction is not only kind of restoration of the ear, but he just comes into the office now and he's just a bright, happy, exuberant guy. And it's just been very rewarding see him in his, see how he's kind of grown and grown into such a great young man. This is another example, a patient with right lobular type microtia. And in this kind of multi-panel figure, it shows essentially kind of the whole process. So preoperative, his little ear before surgery, our planned hemitransfixion incision, the harvest site, the rib harvested, the carved framework after stage 1, after elevation. He had a percutaneous bone conduction device and is just extremely happy with his reconstruction and restoration of his hearing. Some closer up after the first stage, after elevation. This is a patient with a very small conchal type reconstruction, using that remnant cartilage for the tragal antetragal, and he was very happy too. So that is kind of Nagata with elements of Fermin. That's the technique that we're using most commonly. I think it's important to cover Burt Brent's technique. It's an important technique to know about. Essentially, Nagata and Fermin are consolidating Brent's first, second, and fourth stage and separating out that third stage elevation after 6 months. But Brent's technique is the first stage is the framework, separated by several months, then lobule transposition, separated by several months, then elevation, separated by several months, then tragal reconstruction. And typically there's less definition, less cartilage required. And so it is possible to do Brent's technique earlier on. I think a key part of microtia reconstruction is managing complications. So if you do a good number of microtia reconstructions, you will have to manage some complications. I always say the best treatment is prevention, but in kind of knowing when you can be conservative and do conservative care and when you need an urgent revision. So in general, I think concave features are more tolerable to epidermolysis and loss of some of that soft tissue. So this is really a picture you never want to see, where there's cartilage exposure. And boy, whenever I see this, my heart kind of drops. Fortunately, we don't see this often. But this patient, it was close enough to that kind of intertragal incisor that we monitored closely and did conservative care, and this turned out okay. And so we just recently elevated him, and he's been very pleased with his outcome. And so when we think about kind of these reconstructive techniques, it's very much subtractive manufacturing or classic manufacturing, where you're starting with a large amount of material and whittling it down to a desired end product. This is a marble sculptist who's doing the same thing. Additive manufacturing or 3D printing is fundamentally different. It's a bit of a paradigm shift where you're building from the bottom up, layer upon layer. A common technique that we use in our lab is called laser sintering. So a laser is fusing molecules layer upon layer. And one of the earliest initiatives that we did with medical 3D printing was 10 years ago, developing this external airway splint, really driven by Glenn Green and Scott Hollister, just brilliant scientists. And this was to treat life-threatening tracheobronchomalacia. Now this device has been used in over 25 pediatric patients, and it's really just been an extremely exciting process to see. Since that time, we've used 3D printing in a wide variety of applications, and really all of these areas we have active projects going on. One of the exciting areas is high fidelity surgical simulation. So we're able to develop essentially models and do full procedures on them. So Millard cleft lip repair, furlough palatoplasty, really any palate closure technique you like, framework carving techniques. And we've started to develop curriculum around these. So a couple of years ago at Academy in Atlanta, we brought in trainees from all across the country, Canada and UK, and all of the chief residents and fellows were able to do a cleft lip, a cleft palate, ear framework carving, airway reconstruction in a morning. So a really intensive educational experience. We're also using high fidelity surgical simulation for global outreach. So rather than just doing medical missions, kind of integrating education and training of local surgeons within that. An exciting collaboration, we developed an airway model and taught a group of Ethiopian anesthesia residents some life-saving airway skills. Then the pandemic hit, and we were actually in the process of planning our next kind of national effort. And so the discussion was, should we just bag it and wait for the pandemic to end? But I thought it would be just a great opportunity to say, you know, we can still do this. And so we essentially sent out kits with all of those simulators across the country and recruited experts. And simultaneously, we had 35 fellows and 20 expert surgeons from across the country. We had a virtual 3D printed dissection course. It was really interesting to see with all of those elements that we talked about before. Other area that we're using 3D printing is in tissue engineering. And so we can take a patient-specific CAT scan, make a 3D model, include porosity, which we'll talk about why that's important, have a 3D printed ear, embed the patient's own cell in that ear. And this is in a preclinical print, a preclinical implant. So just a closer up of that 3D print with embedded cells and hyaluronic acid. And again, in the preclinical implant. So the porosity, what's key about the design of those micropores is more so than high density porous polyethylene. This is really allowing soft tissue ingrowth. It's really allowing vascular ingrowth. Within a couple weeks, this implant is quickly becoming vascularized. They support cartilage growth well. They support.
All done with your homework?
Except for my practice.
They support soft tissue ingrowth well.
Hold on. Is there someone not on mute? There we go.
And so that is potentially one future direction for Microtia Reconstruction. We've been in discussion with the FDA, and I think we're getting closer. What's nice about the techniques we're using with our 3D implants is they're relatively simple. And so that decreases the regulatory burden and the regulatory hurdles from an FDA standpoint. So potentially not too near off the future. This is just to kind of really recognize and highlight a number of amazing individuals that contribute to this work, especially Dr. Hollister, who collaborates extensively on the tissue engineering, and Jen Kim, one of my amazing colleagues. They're my little ones, and they're on a boogie board here, and we're going to need to upgrade to a long board in May because we're adding one more. So thank you so much for inviting me again. I look forward to any questions you have.
Wonderful talk. Thank you so much. Those ears are beautiful.
Thank you, Maite.
Yeah, it's going to be really exciting when, if this holy grail of tissue engineered ear frameworks comes to be, because especially for cartilage graft reconstruction, that I think the morbidity and the fact that you have to wait for a certain period of time for a child to be old enough, those are all things that Microtia surgeons would like to bypass. So
absolutely,
it'll be, everyone's waiting for that.
Yeah, absolutely.
What modifications do you think, like if you had the ability to 3D print, what modifications to the technique would be required though? I mean, because it seems to be something that has been on the near horizon for a while and then kind of slips back a little bit, you know, for a variety of reasons, be it how the cells behave, how they vascularize. And then if you do get to that point, I mean, do you have to cover it differently? Do you have to adapt the technique at all? I mean, are we at the point where we would know more answers like that, Dave, or is it still too far off?
Well, no, I think we're, so to answer your question, right, Vacanti's ear on the back of the rat was 30 years ago, right? So why hasn't it made it into the clinic? Well, some of the techniques that have been used in the past really have a challenge with withstanding kind of the myocontractile healing forces. And so what starts looking kind of like an ear quickly gets contracted into, a raisin. The technique that we're using is called scaffold-based tissue engineering. And so that structure really acts kind of like MedPore initially and gives that implant a good amount of time before it starts to resorb and lose its structural integrity. At the same time, it's relatively simple. It's polycaprolactone, and we've had a lot of experience now with polycaprolactone and the airway splint. There's a burr hole filler. So there's clinical understanding of what this material is going to do. A lot of the efforts to date have focused on kind of complex manufacturing methods. So pluripotent cells, growth factors. And when you start to add that in, not only does the FDA consider it a device, but they also consider it a drug. And so the regulatory burdens on it have now become significant. And to overcome those regulatory burdens, you have to do a lot of testing, which requires a lot of financial investment. And the routine folks who tend to help with the financial investment, I think sometimes have a challenge seeing the market of Microtia as being worth it. So I think the techniques that we're using are quite simple and from a regulatory standpoint. I think to answer your question, how would we need to modify the technique? Ultimately, I'd like to get this type of an implant back to where Reinisch was initially, where he was implanting it without the requirement of temporoparietal fascia, but without the 40-some% complication rate. I think initially we'll have to do temporal TPFF. It's just going to be the safe way to go. And as we develop experience with it, additional preclinical models, I think we'll be able to get to where we don't need the TPFF. There's some scaffolds that we've tested and recently published on where we looked at finite element analysis of essentially modeling skin draping over an ear shape and looking at where the pressure points are. And then we've designed scaffolds such that you can implant kind of cartilage seeds, punch biopsies potentially from the contralateral contralateral bowl or from the rib, and plug those into those pressure points. And what we see is improvement in soft tissue quality. And there's a few kind of hypotheses of why that might be. I think kind of the skin alloplastic implant interface versus the skin cartilage interface is the cartilage interface, I think, is less strain. I also think that we've shown that those cartilage implants remain viable up to 6 months and probably beyond. It's just, there's only so much money to keep the study going for so long, but that cartilage remains viable. And I think what we see in, different reconstructive methods, different facial plastics methods is you can do injections, implants, and have a impact on the overlying soft tissue, right? And so if that cartilage is remaining viable and the perichondrium is remaining viable, that may be providing some benefit to the overlying skin. But that's just kind of, one example of how we may be able to get there without the TPFF. But, so I think that the method is going to be similar. I think it will be a bit of a hybrid of, MedPore and autogenous rib. But ultimately, boy, when I do these preclinical implants, in the preclinical animal models that I showed, those are without TPFF, obviously, and they healed okay. And boy, it takes about 20 minutes to dissect a subcutaneous pocket and put one of those in. I think, it will require some thought as far as a single versus two-stage potential procedure, if you would need to bring in skin grafts over TPFF. So to be determined.
That's great though, because it just seems like that's the level of complexity that'd be needed. Do you know what I mean? Like just for how challenging a dilemma it is. So that's awesome.
I was going to have a slide with all of the faculty and folks at U of M and Stanford who have spent some time at both institutions, and it's pretty extensive. It's a really awesome group, and I'm so honored to have the opportunity to speak with you guys, and Kay and Mighty. It's so great to see you guys again, and JP, it's great to see you. But I didn't do that slide though because I was worried like I need to get consent from everybody to show their pictures, and I didn't want to embarrass anybody.
Oh no, we love it. You should have just done it.
You might rank right up there against UW and Stanford. There's a connection there too.
You're on both sides though, Dave, right? I mean, because
and there are some folks that have all three.
Yeah.
Yeah.
Right, I have all three, so there you go.
Nice.
Great. David, that was a fabulous talk. Oh, sorry.
No, it's just Lisa. I just wanted to thank you, Dave. That was a terrific talk from a non-microtia surgeon that just kept me totally fascinated. So keep up the great work. That was
awesome.
Really, really exciting.
Thank you so much, Lisa.
Thank you, David. That was a great talk.
Thank you very much.
Yeah, thanks so much, David.
Okay.
Thank you, everybody, for joining. Have a great rest of the evening. Hey, Dave, good luck with everything. Thanks for doing this again. And
of course.
Yeah, fantastic stuff.
We look forward to implanting your ears in the future.
Awesome. Thanks, Mighty. CJP. Thanks, guys.
Awesome. Okay, take care.